Afternoon and welcome. We're glad to invite you to join us, the more than 200 persons who are already in the webinar, to join the Ending Racism Partnership, a blueprint to end racism, with a special focus today on health equity. I'm Reverend Mark Kelly Tyler, one of the co-chairs. I serve as the pastor of Mother Bethel AME Church and also on the staff of Power Interfaith, our Live Free team. This has been quite a year for most of us who are on this call on today, and I don't need to remind you. Um, I'm sorry. I got a message. I think my camera's on. I hope it is, but if not, it's fine. You can always Google me and see who I am later. But I want to make sure you get this very important information. This has been a year of tremendous loss. In fact, as I just looked at my telephone a moment ago at the latest news alert, it was referencing the year of loss that the country has had. And when we think about it, in addition to the 600,000 Americans who have lost their lives, we've also gone through tremendous upheaval. We lost George Floyd, Breonna Taylor, Ahmaud Arbery, Walter Wallace, Dante Wright, and so many other names that could be shared in this moment. I want to pause and just let that sink in, because the reason we're here is because those persons gave their lives up. We are now celebrating, or I don't know if you want to call it a celebration, but recognizing the anniversary of the Ending Racism Partnership, which came about in the wake of that, as some of us sat around virtual tables trying to figure out what can we do in this moment other than sit and watch as the city continually heaved up and down. And so we're here not only to reflect on what's happened, but we're here to try to find some answers. As the pastor of Mother Bethel, I'm reminded constantly of health disparities between our communities. One of the formative stories in our congregational life is that our founder, Bishop Richard Allen, and Absalom Jones, the founder of St. Thomas Episcopal Church, also in the city of Philadelphia, were leading a small group of persons called the Free African Society. They were trying to get new churches started in the early 1790s when the yellow fever epidemic broke out in 1793. They were convinced by one of their benefactors, Benjamin Rush, a signer for the Declaration of Independence and prominent Philadelphia physician, that Black people were immune to yellow fever and therefore could help and serve as nurses for the sick and burying the dead, only to discover that it was not true. Black people had no special immunity and died at the same rate as whites. 10% of the city died in a matter of months. But that did not stop Richard Allen and Absalom Jones and others, even in the face of dying themselves, from putting themselves on the front line, like those that we have witnessed over the last year who did the same during the COVID-19 epidemic. And it is a frightful reminder that we still deal with the same issues of health equity from 1793 to 2021. And with that being said, on today, we're going to be led in a very important conversation with persons who not only know and can diagnose the problem, but also have suggestions for the cure and for the remedy. It's my pleasure to introduce at this time the moderator who will carry our webinar and conversation forward. Please welcome with me WHYY's Health Equity Reporting Fellow, which is also supported by the Commonwealth Fund, Sojourner Ahebe.
Good afternoon, everyone, and welcome again to A Blueprint to End Racism, Health Equity. I'm your moderator, Sojourner Ahebe. As many health equity scholars have posited, we are not actually in the midst of a novel pandemic of coronavirus, but actually what we're seeing is a manifestation, as Shreya Kangovi, an internist at UPenn, has suggested, of a much longer pandemic that's been going on, and that's the pandemic of racism. As the epidemiologist Dr. Kamara Jones reminds us, racism, while not an individual character flaw or personal failure, is a system of power that affects the social and environmental conditions associated with poor health. particularly among people of color, and is an urgent consideration when addressing health disparities. I'm so pleased. Well, today our objective is to explore racism's impact on us, both interpersonally and on the population level. And more locally, we want to ask, what do the experiences of race and racism look like for Philadelphians today? And I'm so pleased to be joined by an impressive panel of speakers. So I'm going to keep their bios short so their interventions here today can shine through. Today, we're joined by Larry Eichel, who is a senior advisor to Pew's Philadelphia Research and Policy Initiative. We're also so grateful to be joined by Dr. Roberta Waite, who's a professor of doctoral nursing and associate dean of community-centered wellness at Drexel University. And finally, we're joined by Arun Prabhakaran, the executive vice president of the Urban Affairs Coalition. Welcome, everyone. I'm so happy to be here with you today. Mr. Eichel, I want to start with you. So in 2020, the Pew Charitable Trust surveyed Philadelphians on city issues. And one of the major results of that survey showed that only about 40% of Black Philadelphians thought the city was going in the right direction. And that was compared to 56% of white Philadelphians who said, yes, the city actually is going in the right direction, marking the largest ever difference in percentage in that sort of gap between Black and white residents. I was wondering if you can talk a little bit about what residents might be sort of including in that assessment of right or wrong, and what the racial gap in public sentiment about the city's future might be capturing.
Sure, and I want to thank the Ending Racism Partnership for inviting me to participate today. When we at Pew ask people about the direction of the city, we're never quite sure why they answer the question the way they do. Right track, wrong direction is kind of a gut check, and we suspect people don't always separate how they feel about Philadelphia from how they feel about the nation as a whole and about their own lives. Now, all of that said, as you said, our survey was taken last summer, and there were some obvious factors that surely help explain why Black Philadelphians saw the city going in the wrong direction. They won't come as a shock to you. One was the George Floyd murder and all that followed nationally and locally. The second was the pandemic, which, as our survey and others indicated, hit Black residents particularly hard in terms of contracting COVID, losing loved ones, and suffering a wide range of financial and emotional setbacks. Finally, there was the ongoing surge in assaults and homicides, which has been concentrated primarily in lower income neighborhoods of color. These elements affected the Black and Hispanic communities more than others for reasons having to do with the structural issues related to equity that have been in place for a long time. And that's likely reflected in those results. Interestingly, white Philadelphians, who as a group were not hit as hard by any of those factors, saw the city as heading on the right track and by a substantial margin, despite all the challenges that last year brought. So it's a fascinating set of results, and I think it does give some insights into what's going on.
Right. Sort of concurrently, Mr. Prabhakaran, the Ending Racism Partnership sort of had conducted a similar study amongst more than 3,000 Philadelphians across racial groups about their experiences with race and racism in the city. And I think what was sort of interesting about sort of what Mr. Eichel was just bringing up about sort of this gap in sentiment about the future of the city in the Ending Partnership survey. Across racial groups, people actually overwhelmingly agreed that people of differing races in Philadelphia do not have equal access to opportunities in Philadelphia. So I was wondering for you, does this consensus mark any significant shift in shared public opinion about the impact of racism, and what might account for this growing shared consensus in the survey results you found?
So first, thank you so much, and I appreciated Mr. Eichel's responses. We did find there are some changing views about race and racism in the city, and this I don't think is surprising. For the first time, there was a survey done earlier this year that said for the first time, the majority of Americans are actively opposed to racism, which is a significant departure from the past. And I think our survey and the citation you provided accurately reflect that change. And I think that people have a growing awareness of how race is playing out in daily lives. And that's, in many cases, the work that movements do to educate the public, to bring untold stories to the front, and to establish new narratives about ways forward out of social and economic conditions that heretofore have plagued our communities. So I'll just make a couple quick notes. In our survey, the main issues that people talked about were criminal justice, education, and housing. And they thought those were the areas where racism exists in prevalent ways in Philadelphia. However, there's a lot more to talk about with this survey, and I'd like to hear a little bit about Dr. Waite's reflections on the past.
Absolutely. This sort of goes really naturally into my next question. So Dr. Waite, according to that same survey, Black Philadelphians were more likely to report experiencing racism in the following categories. So wealth creation, criminal justice, and employment. And so there are some health researchers that might say that a lot of those sort of discrete categories fall under something that we might call like socioeconomic conditions, or it's like a socioeconomic experience, and it has nothing to do with race or racism. And obviously there's a lot of social science research on how not having a well-paying job, living in a neighborhood with high crime, not having access to food and housing sets you up for poor health outcomes. I'm wondering if you can sort of respond to that assessment of it's not race, it's class, and kind of give us tools to understand why race and racism are actually kind of central to this problem.
Sure, and thank you so much for the question, and thank you for the invitation. I think this is an important question. And in response to the assessment, I would start by investigating actually what created these health disparities that we're talking about. Understanding, I would say, both the context currently as well as historically. So an important question to me is, what are the systems that we have built that create these health disparities? So the conceptual areas that we talked about regarding a well-paying job, being in a certain neighborhoods, the educational level, all of those things mentioned truly are actual symptoms of what is produced by structures we have created as humans. So really meaning it's not a coincidence that many of the social advantages and disadvantages, you know, when looking at categories mentioned, align based on race, because race actually captures differential access to power, to resources in society. Therefore, I would say the core driver of health disparities is not race, but racism, which is the ideological process that's rigged to justify inequality, plus the power that goes along with it, and our policies, they align with this. So when we're thinking about racism, it really creates that organized social system with the dominant racial group enforcing actions based on ideology of inferiority, which categorizes people in the social groups that we call race. And these dominant groups use its power to devalue, disempower, and differentially allocate valued societal resources and opportunities to groups defined as inferior. So this narrative also feeds into differential assumptions that we make about the abilities, the motives, as well as the intent of others by race. So I would say essentially that racism truly formed the meaning and the creation of race, which has been man-made. So the differential access to opportunities by race that we talked about within society will undoubtedly be linked with the well-paying jobs, the resource schools and neighborhoods, the quality housing, and the healthcare, and even things we talk about today, such as clean environment. So that really explains the association between sort of the social mechanisms as well as race. But I also, I'm not sure if we have time. I have a couple things here as far as understanding tools that I really think are important, that's really brief. And I think to understand what we're saying about these symptoms, we have to really understand how our house in America was originally built.
Mm-hmm.
And why narratives were differentially created for the select populations in the first place. And I would also say, what has upheld these practices, entrenched power that we have structure, and the policies over centuries? You know, what is needed is to take both individual and collective action to create new narratives that value the humanity of everyone. And just sort of one last quote here, I think that really resonates with me in thinking about this. Something I heard Daniel Dawes really speak about, the author of Political Determinants of Health, is that, you know, as a society, we must care enough, know enough, do enough, and persevere enough until the job is done. And I would say that job is to be on solid ground of realizing health equity for everyone.
Absolutely. Thank you so much for your reflections. I'm reminded again of Dr. Kamara Jones, who talks a lot about when we look at sort of health disparities and sort of these associations between disproportionate burden of disease and racial groups, there's always, she says, there's always some major historical moment of injustice that happened, and you can always just take it back. And so, for example, if you look at something like redlining that made it really hard for African-American families to find houses, quality homes in cities. And then by the time you're seeing them, you know, in health systems, generation after generation after generation, there are these clear health disparities that the community is carrying. And obviously we know good housing is a driver of good health. So if you didn't have access to that for so many years, it's clear there are obviously going to be poor health outcomes. So I think it's really important for us as stakeholders, as community members, to really sort of make these connections because they're there and they're really sort of impacting the way that people are able to live their lives. Mr. Eichel, I wanted to return to something from the Pew study about public safety. So I know for as long as the Pew study has been around, public safety has been a top concern for Black residents who have been surveyed. And so in 2020, when the survey was conducted, again, close to 60% of Black Philadelphians said they felt unsafe outside in their neighborhood. And this marked the largest percentage in the survey's history. And just as significantly, low-income Black residents were more likely to cite that than middle or high-income Black residents. But what was really sort of interesting to me is that at the same time, low-income Black residents were also more likely to say that they could see themselves living in Philadelphia 5-10 years down the line. And that wasn't true of middle and high-income Black residents who said they could see themselves moving somewhere else or leaving, you know, for a job opportunity or for something like that. So I'm wondering if you can talk a little bit about why Black residents with some of the greatest proximity to structural racism in the city might also be sort of expressing this desire to like invest and live in their city.
Yeah, I mean, that's a really good question and one that we have looked at a lot over the years. And our research suggests that there are basically two sets of answers to that question: why low-income Black residents tend to stay in the city, even though it often means living in neighborhoods with high poverty and a lot of crime. Perhaps the biggest reason is that many of them have no other choice. Moving is much easier if you have money. For the most part, housing in the suburbs is more expensive than in the city, with few affordable units. Primarily through zoning, many suburban communities have set themselves up that way. The other reason is that the city has some attraction for low-income residents that other places don't have. People tend to want to stay close to their friends, relatives, to the social networks, programs, and institutions they know, rather than gamble with the unknown in places where they may not feel welcome. And in the city, unlike the suburbs, there are stores on the corner and a public transit system to get you where you want to go. This question also makes me think about a tension that we see city officials struggle with all the time. And that's, to what degree do you craft policies that seek to retain the people who can readily leave, the people who have financial resources and whose tax payments are needed to help support city services? And to what degree do you prioritize the people who have little choice but to stay, the people who depend so heavily on those services?
Absolutely. And yeah, to that point, Mr. Prabhakar, how might like city government and city leaders build on that shared desire that Black residents are obviously expressing to invest in the city, and obviously the city has a desire to invest in itself? And what recommendations does the Ending Racism Partnership have for moving closer to that shared vision of equity?
I think first, and this was evident from our survey, there is a desire for a more honest public discourse about racism in our city. And I think I would address the points that Dr. Waite and Mr. Eichel raised as being a growing body of evidence that suggests that it is racism that is the problem, not one's race. I think the second piece is that we know that racism is ensconced in laws, policies of companies and organizations, and in the public discourse. And so we have to build a reform agenda with specific legislative and policy changes that are aimed to unroot racism wherever it may exist, whether it's in the criminal justice system, education system, health systems, housing, you name it. We should be focused on that in a very coordinated and effective way. The third element of it is we are going to need to make financial investments to undo the long-standing problems that are rooted in our society from its very inception. And we have to focus on initiatives that will focus on the quality of life and well-being of communities of color, Black and African-American communities in particular in Philadelphia, who have a history of being underinvested in and marginalized generally. And then I would just add, one of the things that our survey points out, and I'm not suggesting that the data is in some way conclusive, it's just an interesting observation, is that you see that when you look at who observes racism versus who experiences it, you notice that in the survey that many whites observe racism at a higher rate, as reported, than Blacks or others experience. That means that in some ways, racism is an insider experience for whites. They see it happening even when people of color do not. And that many people of color are unaware that they're experiencing a racist act at the time in which it's happening, because it's so encoded into the everyday life of America. So we have to address that cultural phenomenon.
Absolutely. Yeah, I was actually interested about this question of witnessing versus experiencing, that's sort of reflected in the survey questions. Dr. Waite, I know you've spent a great deal of your career re-educating nurses and health practitioners to think about how health systems are part and parcel of this larger cultural system of racism in the United States. And sort of like the white survey respondents who didn't have the lived experience of, racism itself, but we're still able to recognize it when it was happening, or just say, oh yes, I have recognized racism in criminal justice, or I have recognized racism in employment. What steps can those who don't have that lived experience take to advocate for racial equity in their own lives, in their workplaces, in their institutions?
Yeah, this is a great question. And I would say some of the steps actually are comparable to those who recognize it as well as those who don't. So I'll just highlight some things. And I would say initially grounding, understanding the multifaceted ways racism actually reveals itself. Because sometimes we see things more on a micro or personal level, and then there are things that happen more on a systemic or structural level, which is more of the macro component. But we all have to understand what it is and have that awareness. And it's important to also recognize it's difficult to recognize a system such as racism of inequity that privileges us. So intentionality really is needed on many levels. Additionally, I would say, all of us, and particularly those who want to be advocates for racial justice, you really have to get proximal to understanding the issue. So really partnering with folks with that lived experience, if you're not living it yourself, to truly understand some of the nuances and things that, aren't linked with your lived experience. I would say name it also when you see it. Don't try and use other alternative code words. Let's name it. And also identify when you see it. But once you do that, then what? We still need more action. So like Kamara Jones identified that you mentioned earlier, all of us have to continuously ask, how is racism operating here? That is a classic. How is it operating in our lives and in the spaces that we occupy? Because I still dare to say that for many of us, we live very segregated lives. So when you're in your spaces, recognizing how it's operating and then what do you do about it? So as mentioned earlier, we have to be very courageous and continue to have these frank, honest, authentic conversations and really be bold in those conversations, not be afraid of controversy, when you're investigating it and sharing it. And I would say, embrace the challenge, because this is how we actually know and leverage our power, that we do have. And I would say, don't expect comfort when you're talking about racism. That is a big thing for many individuals. I would say actually expect discomfort and lean into it. This discomfort does not equate to not being safe. And above all, remember to look at the mechanisms that really promote racial inequity. Look at the structures, look at the policies, look at our practices and norms, because these are things that have upheld racism for centuries. And look at the values and continuously be curious and ask why questions, why issues of racial inequity exist, and continue to push that forward in recognizing the past as well as the present. It's not disconnected, nor is it happenstance, but we do have to be curious in our lives. And we must understand to really start to be able to trust each other, but also recognizing that first we must earn that trust and be trustworthy. It has to be earned. And then ultimately organize and strategize to act. Care about the whole society. Continue to engage and contribute perspectives about racial inequity and justice. We talked today about staying woke. Let's stay woke. Let's be present. Let's be determined. Pay attention. See the absence of who is not at the table, what is not on the agenda, and what is on the agenda. And I would say practicing shining a bright light of inquiry, I would probably say, to discover differences in racial opportunities, as well as differences in racial outcomes, and work to expose inaction regarding racial inequities in the face of need, because it's the inaction in the face of need that is the camouflage mask of racism that often escapes the actual detection that we need. And this inaction really will allow us to grow and to really promote efforts to advance what we ultimately want, and that is anti-racism and structural justice for everyone.
Absolutely. I think those are powerful words to end on. And as Dr. Kamara Jones reminds us, racism is a system of structuring opportunity and assigning value based on the social interpretation of what we look like that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, yet saps the strength of the whole society through the waste of human resources. So as we move towards a vision of Philadelphia where all human potential is valued and invested in, we look to our communities to lead the way. Thank you to my panelists today for joining us, and thank you to you all for listening in. Goodbye.
The Ending Racism Partnership is a citywide participatory collaboration of Philadelphia residents, leaders, and influencers. from community, business, government, and philanthropy, to end racial injustice and economic inequality, starting right here in our city. Our partnership favors and champions action in response to this crisis. Our process is to iterate and prototype community-defined preparatory efforts. We started the day after the murder of George Floyd, and we won't stop until we build a replicable model that accelerates racial reconciliation and healing. And this is the charge of the greatest endeavor in our 51-year history, to end racism through the Ending Racism Partnership.
Good afternoon, everybody. My name is Steve Farah. I have the privilege of serving as co-chair of the Ending Racism Partnership alongside Reverend Dr. Mark Tyler and Charmaine Matlock-Turner. And I also have the privilege of serving as Executive Vice President of Public Affairs at Independence Blue Cross. It's my pleasure to lead us in our panel discussion, Equity in Health Systems, today. And I want to first start off by thanking everybody, all the great teams at the UAC, Planning for Perfection at Egypt Graham, IBC's team, and the IBC Foundation team led by Lorena Marshall-Blake and Heather Major. Thank you for putting this work together to help us take steps towards action. A couple things, and we've heard some different terms bandied about. I wanted to take a step back and just make sure that we're all understanding the same thing. Health equity. Health equity means social justice in health, so that regardless of your economic or social standing, you're not disadvantaged in healthcare. And health disparities are the metric we use to measure progress towards achieving health equity. So we've got to eliminate the disparities to achieve health equity. And that has us pause and look at how healthcare is delivered, who's delivering the healthcare, what are the underlying factors, and how do we address these disparities? There's been a lot of work here, obviously, on that. And as previously was said, some of this isn't really going to surprise you. We know that minority groups are underrepresented in healthcare workforce. 5% are Black or African American. Hispanic comprises less than 6% of the healthcare workforce. The Census Bureau talks about the fact that it presents us data that says 18% of the US population speaks a language other than English at home. They also project that by the year 2042, there'll be no single ethnic or racial majority in the United States. So all of this means that we need a multi-level strategy to not only eliminate health disparities, but to improve how healthcare is delivered. There have been numerous studies and efforts to address health disparities. This is not necessarily new. Dating back to Medicare and Medicare's passage, reports from HHS dating back 36 years, specifically on Black and minority health, IOM reports from early 2000s, all beginning to address this. There have been a number of nonprofit studies as well, action plans developed. 10 years ago, a bold plan for action from Health and Human Services to reduce racial and ethnic health disparities, National Academies of Science, and so on. But today, there's something different. Today, in the past year, from all the tragedy that we've seen, and social and racial injustice, and through the COVID pandemic, we see a renewed focus, a renewed energy and urgency to address this. Virtually every major healthcare and provider industry trade group has action plans to address health disparities, including in the healthcare segment, the Blue Cross and Blue Shield Association and AHIP. Independence Blue Cross, as part of under the leadership of Greg Devins, our CEO and president, makes equitable whole person health foundational in everything we do, shaping our health policies, our work with providers, customers, members, and also through our Independence Blue Cross Foundation. So the challenge remains. We have to learn from the past, and we have to harness this urgency and this energy to focus sustainable and replicable solutions. They don't have to be big, they just have to do. And we have to work and we have to learn. That means working differently, more collaboratively than ever before in ways that we haven't worked together previously. This new approach has to then deploy and be measured. So we are at this inflection point in our society on so many levels. But today we have an outstanding panel to guide our discussion, to help us learn more and set a plan to do more. So it's with that I welcome our panel, starting with Dr. Denise Johnson, who is Pennsylvania's Physician General, Dr. Cheryl Bettigol, the Acting Health Commissioner for the City of Philadelphia, Dr. Tony Reed, Executive Vice President and Chief Medical Officer of Temple University Health System, and my colleague, Dr. Rich Snyder, our Executive Vice President and Chief Medical Officer. Welcome, everybody, to this panel presentation. I look forward to this. Let's start with you, Dr. Johnson. And if I could ask you to kick us off by sharing the lessons that you're learning in Pennsylvania and specifically in Southeastern Pennsylvania about health disparities and inequities and the outcomes from the COVID-19 pandemic regarding public health needs and our steps to move forward.
Great, thank you. And thank you for allowing me to join you here today. Certainly we know that any health crisis impacts everyone across the board, but people who have been disadvantaged are going to have a much more pronounced impact. With COVID-19, we have certainly seen that those who have been marginalized, those who are not able to socially distance because of their living situations, those who are not able to take time off work because of that lack of security, those who had to keep working and being on the front lines when they are in high-risk positions, had a significant impact. Also, in terms of their outcomes, those who did not have close access to medical care are going to have more of an impact. So we knew that this has been something that's been ongoing, but the health crisis, these were certainly magnified. We also needed to make sure that we are addressing these disparities that we were seeing. And one of the things that the Department of Health did early on is convene a group of over 100 stakeholders. And those included community organizations that had relationships with people in these groups. We had other community partners, we had health care, we had payers, others getting together so that we could form a COVID-19 health equity response team to look at our response with an equity lens. And so some of the things that we found out is, certainly there are people who didn't have access to testing, easy access to testing. As we went on being able to get vaccinations, get to vaccination sites, to get vaccination information in languages that they understood, to get credible information about vaccination from someone who looked like them or spoke their languages, and to be able to access our information. So to go to the website and get information in another language, to be able to, again, access sites and communicate when there were language barriers. So people who did not have internet, to be able to access information on vaccinations or testing, a lot of that information was only on websites, and so telephone numbers had to be created. People had difficulty coming out of their homes. There were homebound people who needed to be vaccinated. So all of these things, we realized that there were areas of people who couldn't get testing, who couldn't get evaluated, who couldn't get vaccinated because of these barriers. And so we had to address those barriers as we had the COVID response. Learning from that going forward, we've worked with our Department of Human Services, as well as the Department of Health, to look at now how do we go forward? So we've noticed that there are these inequities, these disparities, and as mentioned, I believe Dr. Wade said, these are symptoms of a larger issue. So how do we position ourselves to go forward addressing this in terms of health? Health is not completely independent. And so we know that as we look at things like the Social Vulnerability Index, there are communities where health is impacted because of these structural systemic issues that occur. Things form some regional health councils. And so these councils are composed of payers, providers, as well as community organizers and other stakeholders to look again with an equity lens and determine, so what are the root causes of the issues that cause this community to be more vulnerable, address those issues. So if maybe it has to do with transportation, maybe it has to do with housing, maybe it has to do with job opportunities, to find a way to look at those structural issues that impact the health of a community and start to address them. So a lot of lessons learned from the pandemic. It really magnified the inequities and the structural issues that we had. And going forward, we need to address, again, not only the symptoms of those issues and those structures, but we need to go to the root causes and affect some change there if we want to have some lasting impact.
Thank you, and we'll come back to that issue of root causes and next steps, I think, in our broader discussion. Dr. Bettigal, from the city's perspective, what has the city learned and some of the lessons that we've taken to address the issue of health disparities and addressing them in our community? Good morning, good afternoon, and welcome.
Thank you. So first question is, can you hear me?
Yes.
Okay, marvelous. So my internet went out, so I'm now talking to you from my phone. So apologies for that. But thank you so much for this panel and for this discussion. So, you know, from the city side, I really strongly agree with what Dr. Johnson said. With any public health problem, any public health emergency, we knew this, but I feel like we didn't know it in our bones the way we do it now. That, you know, the pervasive effects of racism and other kinds of prejudice are such that we can pretty much assume that any public health emergency, any public health problem is going to hit Black, Latino, and other historically discriminated against groups the hardest. And we need to think about that not as special populations, which is where it typically appears in public health planning documents, but as front and center, this is where we start our planning. So I think that's the first and maybe the most important thing that we've learned. Second, you know, thinking about our trusted community partners and making sure that our trusted community partners really are trusted community partners, but then building from those relationships. Public health departments are not immense. We are not an army. And so thinking about how do we partner effectively with the community groups and have the relationships to really reach people. Data. Data is really critically important to public health, but I've never seen data become so critical to us understanding where we are and where we need to be. And so, you know, that means disaggregating our data. And so one of the things we learned fairly early in the pandemic was that we needed to look not just at race and ethnicity, but also at age group, because only by stratifying by age group did we start to see some of the disparities emerging, particularly for Latino city residents who are a younger population. And we knew they were a younger population, but we didn't realize how much that skewed the data until we did that stratification. And then data on all the groups that we don't yet have data on. So we look at people in groups that don't necessarily make cultural sense or public health sense. All of Asians are one group in our data, and yet are very much varied populations. The Latino or Hispanic population, very, very different issues for people from Puerto Rico versus people from Mexico, people from the Dominican Republic. And then other groups that we don't have very little data on, including people living with disabilities, LGBTQ populations, groups that we just need to know more about if we're going to be effective in public health response. The need to recruit and retain diverse staff at all levels of our department has never seemed more important. People react to who we are, and if we are represented only by people who don't look like community, that is very important. We are a diverse department, but really looking closely at all levels, and working to recruit and retain people from diverse backgrounds, lots and lots of talent in our city. So that's become another priority. And then finally, the need to revisit all of our planning and preparedness plans for public health emergencies with the 4 things I just listed off in mind, which is front and center as I would not say this pandemic is over by any means, but we're having a little lull, and it gives us a little time to think and to plan and to do that with what we've learned very much front of mind.
Thank you, Doctor. I don't want to cut you off.
That's my short list.
Well, I took good notes, and it was really important. Again, it'll help tie everything together in terms of some actionable steps, hopefully. Dr. Rich Schneider. Rich, could you share the perspective of independence as a region's leading insurer and a payer in healthcare, and what we're doing as an entity to address health disparities for members of community and our providers?
Sure. So good afternoon, everybody. It's a great opportunity here to hear all of the perspectives, and I value that a lot. As independents and as a prominent and longstanding organization in this community, our mission has and continues to be to enhance the health and well-being of the people and communities we serve. That said, I think we first need to acknowledge that there is a problem, and as we heard in the first panel, that may be painful, that may not be easy, but it's really important. And for us, when we think of it from a health equity standpoint, the way I view the problem, Philadelphia ranks 67th out of 67 counties in terms of overall health rankings, health outcomes, and quality of life. That's compared to the counties around in the other 4 counties. Delaware County ranking 34th, Bucks County 5th, Montgomery County 4th, and Chester County 3rd. So if you think there's unwarranted variation there, that would be the case. There's enormous variation. And it all goes back to some of the resources that were talked about in the first panel and the opportunities or lack thereof that were mentioned there. It extends into the health outcomes and the life expectancy in this community as well. If you look at the lifespan in Society Hill versus Strawberry Mansion, there's a 20-year gap. Why? That's truly unwarranted. If you look at the death rate for Black women who go through a pregnancy, 73% of the deaths are attributed to Black women, yet only 43% of the pregnancies. If you look at other more chronic and insidious kinds of conditions like diabetes, here in Center City where I'm sitting at the moment, and you're sitting, Steve, 6% of the population has diabetes or suffers from that disease. Whereas if you go into parts of North Philadelphia, you're at 20% of the population. And if you look at obesity, here where we're sitting, 20% are obese, and in North Philadelphia, 45% are obese. Truly unwarranted, driven, in large part by not only access to healthcare, but a whole host of other social and upstream conditions that we need to address if we're going to have any impact on health outcomes. And I know, speaking for Cheryl and Tony, and probably Dr. Johnson as well, even though I know you hail from the western side of the state, we're not satisfied, and we're not going to be satisfied with being 67th out of 67 counties. We want to jump over a few counties and improve the lot of the citizens of Philadelphia. Now, how do we think about it as a health plan? you know, the Blue Cross Blue Shield Association came out with a pledge some time ago. And the highlights of that are, first and foremost, we pledge to act. We pledge to listen and learn. We pledge to create and maintain a forum for our associates to speak. We pledge to make our voices and our actions known both inside and outside our company. We pledge to be part of the change we wish to see. And finally, we pledge to not let things ever go back to the way they were. That speaks about change, enduring change, persistence on the part of all of the Blue Cross Blue Shield family of companies. And Independence has signed on to that pledge, and our mission speaks to it. But what I think is a little bit unique at this point in time is we've just concluded over the past year and a half, refreshing our 5-year strategy. And the focus is on equitable whole person health. And equitable being, in this case, defined for us, narrowing race, gender, based and other disparities in access, experience, affordability, and outcomes. The whole person health part just deals with physical, behavioral, social, and a major tenet of our strategy is to promote equity. We have a large war chest of human and financial capital at the ready to work on that. The specific area I'm going to focus on is health equity, since we have limited time, and as I think Cheryl would attest, the one variable that's most frequently associated with life expectancy in Philadelphia is jobs. And so economic equity and health equity are linked, and we're focusing on both of those in a major way to put more money, more vendor spend into the hands of Black and Brown community companies. And as well, we have fairly significant investments that are reserves in the event that our members, our customers, could not pay their bills, and we're still on the hook to pay Tony and his buddies delivering healthcare on the front lines. Those are invested far more than most companies in companies that are minority led. So let's talk about health equity for just a minute. The Blue Cross Blue Shield Association has decided that, and in conjunction with us and others, that our initial focus in 2021 is going to be on severe maternal morbidity, which is a CDC measure of 21 indicators that lead to that 73% of the deaths being Black women. We're going to address that. We're going to beat that. We're in the next 5 years. We've committed to reduce it by 50%, which may not sound like a lot, but when you realize that the measures are things that have long lead times, years in many cases, it's going to be hard to move the needle on that. The second topic that we're focusing on is behavioral health. In our market here in Philadelphia, Blacks access behavioral health in underserved communities by about 40 to 50% less than whites who live in those communities. And there's got to be a reason for it. We've got to understand that. We got to fix it. We here at Independence have been analyzing our data for a long time, but more recently putting a lens on it, looking at specific zip codes and understanding that if you're Black, your likelihood of accessing specialist care, it's about 500 visits per 1,000 members per year fewer in underserved communities than whites. If you're a senior and you're Black, it's about 900 to 1,000 visits fewer per 1,000 members per year. What I'm saying is that not only is there a gap in the outcomes, but there's also a gap in access. There's a gap in utilization of services that are available, and we need to fix that. Independence, as I indicated, has spent a fair amount of time prioritizing and focusing on what we're going to work on and how we're going to work on it. And while we haven't unveiled the larger effort, which will be in conjunction with all of the health systems in Philadelphia County and community organizations, that effort will focus on pilots in discrete areas initially to see what works. And then we hope to scale that across the entire city and hopefully beyond. But our mission is to change the outcomes. And to do that, we're going to have to move upstream to a lot of the health behaviors and some of the social determinants of health that others have talked about. And we will do that. And we'll do that under the umbrella of a publicly available report card that shows just how poorly we're doing in Philadelphia today. And, I know that all of us who are working on this project want the legacy of knowing that we've changed that report card. So that's how I think about it as a health plan. I think we can have a change working with our partners in the community, and we will.
Yeah, it's a great point. We'll come back to about community-based, trusted sources, et cetera. And before we go back, go to Dr. Reed, Rich, there's one element that I've had the pleasure through working with you. If you could share the story, how implicitly there has been bias in healthcare as it relates to when you talked about kidney disease and how measures are looked at within the Black community vis-a-vis other communities. And then what we've done about it.
Right. So there's a lab test called eGFR, which is kind of a calculated kidney function test. And if you ever look at your lab results, they will give a number and they'll say if you're, for the eGFR, if you're Black, it's actually adjusted. When you look at the history of how that happened, it's pretty unclear as to why it happened. Allegedly, it was for valid reasons, although it's a little hard to trace the origins. The impact of it is significant. One health system here in Philadelphia that received an innovation award from us noted that 20% of the people with stage 4 kidney function or end-stage renal disease would have been eligible to be in the transplant list if they were not Black. And that is troubling. That's very troubling. There is an effort to change the guidelines. And what I've done in the last couple of weeks is to send a letter to each of the hospital and the health system CEOs asking them to change that and drop the adjustment from their lab testing. And I also did the same thing with LabCorp, which is the exclusive lab provider for Independence Blue Cross for the outpatient side. And I've gotten affirmation from most. Jefferson will have eliminated it by the end of the month. Penn, Temple, Holy Redeemer, LabCorp, and Trinity are all in the process of removing the adjustment. So it should enable more Blacks to achieve equal care for end-stage renal disease going forward.
It's something that seems so basic yet so profound right in front of us. And I'm sure there's more out there. And thanks for your leadership on that one. Hey, Dr. Tony Reed, what's your viewpoint from the front lines at Temple University Health System? And can you share some examples of what's working with some of the patients that you serve?
Yeah,
thank you.
And thank you for having me. As I stand here and listen, it's one of the advantages of being the last person to speak is that I get to hear everyone else's insight. And I can say at the start of my remarks that I am absolutely the least qualified person here for this panel. It's a wonderful panel that you've put together, and it's a great session. And I see in the comments, we're talking a lot about the Black community. I will try to weave in some of the brown community in what I'm about to say. I also do want to clarify one thing for Dr. Snyder. Mike's letter was not entirely accurate. We eliminated the calculation a year ago. Our chair of nephrology is a Black woman who realized that it was inequitable. And so we changed that process in our lab calculation. Now, what they did do initially was put in two pieces, one in the correction factor, one without the correction factor, with education about the lack of evidence around the correction factor. And so rather than just take it out and leave our doctors asking the question why, we chose to educate and pull it out, and then subsequently removed it. And so that's one of those examples of things that we do internally here with our own education and with our own desire to really tackle a trifecta of issues in diversity, equity, and inclusion. And so within our community, we also do the same. It's a lot of focus on education. It's a lot of focus on access. It's a lot of focus on the social determinants of health, as well as our everyday daily effort of building trust in the community. It starts with us. While I'm obviously a white man as the CMO, 50% of our management are minority. We have a large proportion for those in gender equity. A large proportion are female, including my counterpart who leads our physician group is a woman. And so that's all purposeful. It's looking at it from the perspective of we should be reflective of the community, a broad, proud, diverse group here in North Philadelphia and in the areas that we serve. The other things that we do, we spend the time talking to people about what their needs are. And so we're part of a number of community groups, whether it be through the hospital directly and Steve Carson and our Center for Population Health, through our Center for Urban Bioethics and Kathy Reeves, or through the College of Public Health with Sue Scanlon and Sarah Bass. When it came to education around COVID, that's where we started. We pulled out our primary care docs, Drs. Wardlow and an ED doc, Dr. Kaby, both Black women, one from the community, one from just outside, along with Sarah Bass, who's our researcher in risk communication, and asked the basic question: what is it that the community needs to know? What services are necessary? Where can we do testing? Where can we get vaccination? What words do we use in this process and what do we not? Our own research told us that words like combating the virus, fighting COVID, not preferred. It sounds like the war on drugs. It sounds like the battle that happens in the streets of North Philadelphia every single day that keeps our trauma program unnecessarily busy. The preferred messaging was around personal responsibility and commitment to each other and commitment to the community. And so we changed our messaging to match that. We also took the vaccine to them. There was a great strategy of a large mega center in Center City. We knew our population wasn't going to travel there. Some of them can't even get there. And so while that was going on down there, which was a Herculean effort and needed to happen, we loaned out the Leah Corris Center to the Association of Black Doctors so that they could work there. And then we put our people out in the field. We had a site here on campus at the university, at the med school, but then we put Dr. Reeves in the vans. Went out to community groups, community centers. They were part of our community collaboratives. And whether it be part of the Lenfest 10, whether it be part of, Lenfest North, or whether it be part of, any of the other collaboratives, it's that continued commitment to working with them, bringing resources to them, being out and mobile in the community, and then bringing those learnings back and applying them here in the hospital and in our offices. Somebody had mentioned the maternal and child health issues and maternal death. Yeah, the rate for infants in Philadelphia is nearly twice the national average. And so we started a baby box initiative several years ago, looking at it from the perspective of SIDS, sudden infant death, and how do we cut down on those mortality rates? We've now evolved that into the maternal mortality issue. I'm proud to say we've not had a maternal death in over 5 years, but that doesn't mean the issue doesn't exist. And that's where our education efforts in maternal child health happens now. That's where we start looking at what are those factors, what are those social determinants that will play into that. And we're part of the PA Perinatal Quality Collaborative around it to see what can we do to improve that. We also noted that stable housing was a major factor. And so we're part of a Housing Smart initiative. It's a 2-year program to help 25 homeless Medicaid patients who frequently use the ED get stable housing. And we've placed them in there and they've remained. And what we found, the use of the emergency department has gone down. They're connected with primary care docs, and we're looking for the next step in that process of how we expand from there. We're also part of numerous food kitchens and other resources. I think our violence prevention program often speaks for itself with the work of Scott Charles and Cradle to Grave, Turning Point, Fighting Chance, Safe Bet, the Gun Lock Initiative. That's really where we started, was in all of those. And those are the things that were important to us. With regards to the communication and communication of language, what we learned is that 20% of our patients don't speak English as their primary language. Most of it's Spanish, but not all. And so we made a concerted effort in the last year and a half to be out on the Spanish language channels. Dr. Natalia Ortiz, who is from our psychiatry department, Dr. Dan Salerno from our pulmonary medicine group, have been on, if not weekly, certainly every other week throughout the pandemic to help guide and give education and to provide resources. That's part of why they put me out on a lot of the news channels, to be able to provide that education. That's part of what Dr. Kaby, Dr. Wardlow, and Dr. Reeves have done over the past year and a half, is getting that word out in whatever venue we can. The marketing strategy around it was large scale, small scale, local, using the community resources. And then the last thing I'll say, just in terms of numbers, I mean, people know the general of where Temple is located and what we have. Some of the interesting things that I live to work to every single day, over 75% of patients in our immediate service area identify as Black or Brown. And so our obligation is to help match that and to help be in that and to grow from our community a workforce. And so we start to do that in workforce development. 86% of our inpatients are covered by some government program, Medicare or Medicaid. 45% of them are Medicaid, 41% are Medicare. Of the Medicare, 50% of them are known as dual eligible, meaning they have both Medicare and Medicaid, which is one of the national markers of poverty. And so that translates into 45% of our residents who live here in our primary area are living below the federal poverty level. And so we've made all of those prior commitments and making the ongoing commitment to how do we work to resolve that? How do we get at those disparities? And how do we make access to healthcare more equitable for all? I'll stop there and come back to you, Sue.
Thank you so much, Tony. I think, so we've heard a lot. We have a little bit of time left. I want to save some time for a question or two, but I want to put this out there to anybody who wants to jump in from the panel. So we've heard things like trusted sources, the need there, the use of data in new and different, more sophisticated ways, recruitment and retaining diverse staff, as Dr. Bedeville shared, revisit all the plans and the engagement that we've had as a payer, as from public health, economic development. Then you've gotten into things from maternity care, diabetes, obesity, infant deaths, all those entities, not just from an underserved community writ large, from the Black community to the Latinx community and for instance, the Asian community, and the differences with which you have to operate within the cultural competencies and sensitivities within each ethnicity. So I'm throwing all this out there. That's what we've heard. Now we're going to say, take a magic wand. How would we start something actionable? Would it be by ethnic segment? Would it be by condition? Would it be by focusing on trusted sources of data? The concern is that we're so big that we're not going to be able to take thin slices and really move the needle. Any reactions to that?
Can I throw out one?
Yes.
The conversation that I've been having with Rich and some other folks that he's brought together, which is that as far as we can tell from the data, this really does at its core come down to living wage jobs. And that's, poverty obviously is very closely connected to all the outcomes we're talking about. Poverty has racism at its roots. But if there's one place that we can identify as a starting place, it's about jobs and living wage jobs. And, there are longer range things and things that require people outside our institutions to think about, and we need to push for those things. But for those who are part of healthcare institutions, looking inside as well, looking at, what's our base salary at all of our institutions? Because there are a lot of people employed in healthcare in city and in this state? And are they being recruited from the neighborhoods served by the institution? And are they being paid a living wage? Are we making sure that when we hire people, we hire them full-time with benefits? And are we creating pipelines to better paid jobs, promoting from within and so on? Those things actually matter a lot. And so there's an analysis that we did a few months back looking at chronic unemployment and mortality and finding very close linkages. There's another analysis that we'll be putting out shortly about chronic unemployment and gun violence. But these things are all closely linked. And, undoing racism obviously is huge. But starting with these building blocks that matter to individuals, looking at how we recruit. One of the things that we've done internally is put together a workforce recruitment kind of toolkit to help people rethink, is your first criteria that the person graduated from an elite institution? Well, we know that's kind of a marker for race, so maybe we should rethink that. Are we valuing lived experience when we recruit? Things that can make a big difference. I'm sure there's a lot more that can be said about this, but I'll stop with those.
I think where I'll go, because I'm going to go back to, you said a magic wand, and I'm a big Harry Potter fan, so that resonates with me. If we had a magic wand to wave, I would almost wave it as a make the world colorblind, so that our first thought in our mind is the person black, brown, white, or otherwise. So that one of the questions on how we treat somebody is not race and ethnic background. And so that we are looking more at the individual instead of the category. And the same could be said for anything, and stepping into dangerous territory. I don't care if a person is Democrat or Republican. What I care is who they are. One of the things that we say around Temple is that we all bleed red. We are all one in that, and we are all unique in that. And so it's a one-on-one conversation of how we deliver equitable care to that individual, and how we make sure that that individual has the resources they need, regardless of race, creed, religion, and all of the other factors that go with that. That's the big magic wand in that. But I think we've got to take steps to get to that point where we've started, and where I think the world needs to get is the recognition of the unconscious bias. We all have it. And the unconscious bias needs to be diminished while the conscious bias increases, and then we can address the conscious bias. But while it's unconscious and subconscious, we're never able to address it. And so it's exactly what they talked about in the first panel. You've got to draw that out. You've got to have that conversation. You have to make sure people understand the questions they ask, the perceptions they have. Those are all part of our biases. The elite institution, I never even thought about that until Cheryl just mentioned that. I'm a graduate of Delaware State University. I don't look like a typical graduate of Delaware State University, but I am. And that's where we need to go is, do you have the qualifications, regardless of where you went or who you are? And then we move from there.
Yeah, I'd like to jump in here. I agree with Dr. Reed. I think that there is a place for destigmatizing the unconscious bias training. I think that it has become now a buzzword, and people believe that we all treat everyone equally, and don't recognize that we have these biases. And I think that there needs to be a removing of the stigma of that, to know that yes, we all have it, and we all treat people differently for lots of different reasons, and that needs to become front and center. It needs to be recognized and embraced, and then mitigated. And I think that in terms of dismantling racism and understanding that there are structural barriers that exist that, as mentioned before, preferentially advantage some and disadvantage some. And so we need to take away that sort of trigger or buzzword around those tasks that we need to do to move forward to make sure that people are accessing equitable care and having an equitable experience in housing, in employment, and all of these other areas as well.
I guess the issue in closing for some reaction is that while the color blindness brings some of the uniqueness to who we are, both as a society and some of our own health conditions, how do we take the approach of being colorblind, but also recognize that uniqueness, what makes us different, makes us stronger, but also has to be dealt with in terms of engagement with different communities. We've heard some regarding the differences in the Latinx community, both in engaging care and accessing care and providing care than, let's say, the Black community and so on. So how does this issue of color blindness and the uniqueness of our ethnicities help shape our engagement in health equity?
So just a quick comment here. I don't believe that we can be colorblind until we address the inequities, right? So the structural inequities that exist, unless we address them, then there's not a role for being colorblind, because then we can't have equity because these systems are in place. So I think we need to look with a lens and identify what those barriers are and start addressing them before we can say that we're truly colorblind.
Anyone else?
Rich, you're talking, but you're muted.
I do that all the time. Sorry. Now, I was saying, you know, I saw the comment flash up that we need to get to know each other. And I think one of the things that I've over the years felt like has been just enormously a successful approach to moving the needle on anything. It doesn't matter what it is, whether it's something that's race related or not, is to get more people involved, get collaboration. And you know, it's like I didn't know Tony from a hole in the wall a year and a half ago, and I spend every Thursday evening with him now, and I know him, and I know he's the most sincere person here when he tells you that he's serving this community in North Philadelphia. He is, and I would I could you know, vouch for him at any time. What I feel is that when you get to know somebody, it's really hard to turn your back, right? I mean, I don't know how others feel, but one of the things that we've done at IBC over the past couple of years, couple of things. Number one, Health Share Exchange, our HIE, was an effort not by a few to build something and force others to use it, but a collaborative effort of all the health systems, initially all the health systems and the payers in the region. The CPR Ready, the effort to teach people in the community to learn CPR, was an effort across many organizations. And we may have slightly different motives for doing something, but if it's the right thing to do, getting more people involved is really, I think, a way that we need to go with this. If you think about the health equity issues, there have been many singular efforts to move one measure here, one measure there, and they haven't really done a whole lot to move the overall needle. We're still 67 out of 67. And I to the group that Cheryl alluded to, you know, I use this example all the time. If we each throw a pebble in a pond, you don't get much of a wave. If we heave an enormous rock in the pond, we're going to get a wave. We're going to get something that's material. And if we do it over and over again, we can have an impact. And I think that the key things here are you have to be sustained. Whatever the effort is, it has to be sustained. Two, it has to be coordinated and collaborative. It has to be across all of us, not just one or two organizations. And three, it has to go upstream from health outcomes. Health outcomes are a reflection of a lot of other things upstream, like insecurity relating to food, housing, transportation, money to buy medications, even just having providers that look like me to go to, which I think was alluded to earlier. Those are all things we have to work on as part of the overall solution. It can't be just focused on getting people to appointments. That doesn't fix the upstream causes for why the outcomes are not equal.
Well, with that, Rich, I want to thank you and thank all of our panelists for not only participating today, giving a ton of thought-provoking information for us to go with, but also your passion to this work and the work that you're doing every day for our shared goal. So thank you very much. And with that, I'll hand it over to our leader, Charmaine Matlock-Turner. Good afternoon, everybody.
Steve, thank you so much. And thank you to all of the panelists on both panels. This was such an important conversation. And I can just tell by following the chat and some of the questions that this is definitely an area where people want to talk. More than 3,000 people, as Arun said, completed the survey. So we know that taking the covers off of racism and really having strong and honest conversations, uncomfortable conversations, as was said earlier, is absolutely critical. I also want to thank Reverend Tyler, along with our esteemed panelists and our co-chair, Steve, along with Mark Kelly Tyler. He noted at the start of our event, while we were hosting conversations today, this also is a time for us to act, and we can hear some of the action that's being taken, but we know that we have more to do. We need to be intentional, and we have to be committed to ending racism. It is an injustice in our world, and every action that we take that gets us closer there shows that we are making progress. As Reverend Tyler said earlier as well, a lot can happen over the course of a year. It's been more than 1 year since the murder of George Floyd, as all of us watched that tragic murder live, unfortunately, on our televisions. 1 year since the spark of nationwide unrest and protest in response to repeated acts of police violence against Black Americans. And 1 year since the Ending Racism Partnership took steps to advance our pursuit of justice in all of its forms for our communities. It's been a year when we have also seen disproportionate suffering in BIPOC communities due to the COVID-19 pandemic. And we've seen horrific instances of Asian hate and other instances of race-related injustice against Black and Brown people, LGBTQ, and too many others in our communities. Even in the last few weeks, we as a nation have had national discussions and remembrances of the 100th anniversary of the Tulsa Massacre, one of the worst incidents of racial violence in an American city ever. Yesterday, I joined the mayor in memorializing Octavius Catto. I hope that you get a chance to go by City Hall to see his statue, who was a terrific Philadelphian and American, and yet who became a martyr to racism as he was shot and killed while he was organizing people to vote in Philadelphia in 1871. And this Saturday, June 19th, we observe Juneteenth, the holiday celebrating the emancipation of those who had been enslaved in the United States. It was 155 years ago when the last enslaved peoples knew that they were free men and free women. Before that day in Galveston, Texas, and over the last 155 years, individuals have been working to end racism and injustice in our world. That is why the work of the Ending Racism Partnership today is so critical. It is our turn to lead, our turn to inform, our turn to inspire, our turn to empower, our turn to lift up this new generation of people to continue the fight to end racism. Yes, I know we have a long way to go, and yet we continue to take big steps forward. And I believe this conversation and the work today is going to help us do that. I'm extremely proud of our partner and co-convener in this work, Independence Blue Cross. They have led the charge and have put together this amazing event. Thank you. I ask that you all take a moment and reflect on the last 90 minutes we spent together. I know there are those who've asked for copies because we did record this, so I'm sure that we will make that available. Our first panel helped us to understand race and racism, and very specifically, how it looks in Philadelphia through their own expertise, as well as their own experiences, and from hearing from 3,000 citizens in our citywide survey to make sure that it's not just us who are talking, but that we are listening and hearing people in our community and in our region. We heard from some of the highest levels of the healthcare sector in our second panel. Thank you so very much, city, state, and local leaders and leaders in our region. And for over an hour, they talked about race, racism, and equity in healthcare. These are powerful things. So what's next? I encourage you to learn more and take action to move this conversation forward. First, learn more. I invite you to visit endingracismpartnership.org. There you can download our sentiment survey report and review the findings from more than 2,000 respondents who provided their perceptions of racism and its impact on their communities. Take action. If you haven't already, again, please go to the endingracismpartnership.org and sign up to stay involved in this work. Today's timely topic of health equity kicks off the second phase of the partnership's work, which is focused on establishing priorities for healing and rebuilding from systemic racism. This work will take many more people, experts, and perspectives as we dive deeper into the pillars of our society, like health, education, employment, and criminal justice. Lastly, and once again, let me thank the co-chairs of the partnership, Reverend Tyler, Steve Farah, Independence Blue Cross, my entire team at UAC, who did a terrific job, to all of the 25 members of the steering committee who have stayed connected to making sure that we are going to stay focused on this work, and again, to our moderators and panelists who are here with us today. Thank you to each of Graham from Planning to Perfection, who helped us organize this work today. And again, thank you to all of you who joined us, who signed up to say, I want to be a part of this. We have so much work to do to ensure that events like the Tulsa massacre, the killing of George Floyd, and the disproportionate impact of COVID-19 on Black communities is remembered, but that it never happens again. By working together with open discourse, we can get there, uncomfortably there, but we can get there. We can end racism. Thank you, and please stay connected and let's fight this together. Thank you very much.